Welcome everyone, and thank you for joining us today for this live webinar brought to you by VIA, VitaFlow in association with you. We're very grateful today to have a very international audience joining us from all over the globe, so welcome to all of you wherever you may be. My name is Elisaveta Johnson. I'm a registered dietitian on the Medical and Scientific Affairs team at VitaFlow North America. We are excited to introduce today's speaker, who is a very well-known thought leader in the specialty of therapeutic ketogenic diets for the dietary management of intractable epilepsy. Today's topic is low ratio, slow outpatient ketogenic diet initiation. A few housekeeping items before we get started. You can access the PDFs of the handouts in the handout section in the right-hand side control panel. If you are tuning in via phone, please don't worry if you cannot access the slide deck, as it will be emailed to you at a later time. Also, please note that this program is being recorded. Financial support for this presentation was provided by VitaFlow USA, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented, is for educational purposes only, and is not intended as a substitute for medical advice. This program also offers one continuing education credit for dietitians and DTRs practicing in the United States. You can download your certificate from the handout section in the control panel to your right. And for whatever reason, if you are unable to download the handouts or certificate, please do not worry. You will receive an email with both of those documents with a download link at a later time. We will also have a live Q&A following the presentations. Questions can be submitted by typing into the questions pane of the control panel to your right. You can type a question at any time during the program. We encourage our audience to type in the questions throughout the program to streamline the process at the end and ensure we have adequate time. As with any program for CE, questions relating to product will not be addressed. Feel free to contact your VitaFlow representative for further product information following the program. And at this time, I will gladly hand over the reins and the mic over to my dear colleague, Bridget Lambert, who is tuning in from our global head office in Liverpool, UK, and she will do the honors of introducing today's speaker.
Thank you, Elisaveta. I'm delighted to introduce our speaker for today's presentation, Jennifer Farbe. Jennifer is a registered dietitian and works at McMaster Children's Hospital, Hamilton Health Sciences, Hamilton, Ontario in Canada. She is also president of Matthew's Friends Canada, a charity specializing exclusively in medical ketogenic dietary therapies that provides information and support to families and healthcare professionals, and is a member of their medical advisory board too. Jennifer first started working with children on the ketogenic diet in 2001, and since then has gone on to develop an innovative approach to its initiation, the low ratio, slow outpatient method, details of which she will be sharing with us today. For the past 15 years, Jennifer has been actively involved in training and supporting healthcare professionals in ketogenic diet centres in Canada and other countries, for example, New Zealand and Moldova. She has been an invited speaker and lecturer at a wide range of keto-related events, both at home and globally, regarding the initiation of the ketogenic diet. Jennifer has contributed to the creation of practice and evidence-based educational tools for dietitians in Canada, developed other keto diet training materials used locally and internationally, and co-authored research papers in the diet therapy section of the Ontario Epilepsy Guidelines. Jennifer, VitaFlow USA would like to thank you very much for taking the time to speak on our behalf today, and without further delay, I will now hand over to you to begin your presentation. Thank you.
Good afternoon, everyone, and greetings from Canada. This is Jennifer speaking, and I'm going to take you through the evolution and rationale of a method that we have used here at McMaster Children's Hospital for several years. So I thank you for joining. In the United Kingdom, we have a branch here in Canada that serves to provide evidence-based information regarding medical ketogenic diet therapy. All right, so the objectives of today's presentation is to provide a general overview of the methods of initiation and titration of ketogenic diet therapy for epilepsy, then review the low-ratio slow outpatient initiation method that we use here at McMaster Children's Hospital, review the safety and tolerability data of low and slow method, and then review sustainability of the outpatient method using the food exchange system. Just a delay in advancing the slide. So I'm going to... Okay, so the ketogenic diet. Now, most of the audience that we're having today will know what this is, but as a quick overview, the ketogenic diet is considered to be a medically supervised diet therapy for medically refractory epilepsy. It is a metabolic therapy that is high in fat. It is a diet high in fat, designed to mimic the metabolic effects of starvation used in the management of epilepsy and other related disorders. It is also characterized with adequate protein and as low carbohydrate. As we have the ketogenic diet, we take in as a diet that is high in fat, adequate in protein, low in carbohydrate. Our natural fat metabolism process will be that we populate the free fatty acid pool that will enter into the mitochondria and then create a pool of acetyl-CoA. The acetyl-CoA will enter the Krebs cycle and yield energy. However, in the ketogenic diet, when we shift a lot of our macronutrients over to a high-fat diet, we will still generate the acetyl-CoA, but then we will come to a point where we will overwhelm Krebs cycle, and then we will shunt over, and from the acetyl-CoA become a backbone to creating ketones such as beta-hydroxybutyrate and acetone and acetoacetate. And from there, we can go into the biochemistry of its anti-seizure effect. But that is not the point of our presentation, but just giving you a high-level overview of how the ketogenic diet would work. Now, with the efficacy, many have asked, what is the efficacy of the ketogenic diet in children, adolescents, and even in the adults? And in 2018, there was a Cochrane Library review put forward by the Martin and McGill group. And in that group, I'm just going to advance that slide, there was 11 randomized controlled trials that were surveyed, and about 15 publications that were reviewed. And of that, 712 children and adolescents comprised the analysis, and 66 adults. The ketogenic diet was evaluated at the endpoint of 3 months, and what they identified with the classic ketogenic diet of 4:1, that there was seizure freedom and seizure reduction analysis. So seizure freedom was achieved up to 55% in the classical group, and seizure reduction up to 85% in the classical 4:1 group. With the modified Atkins group, they did find that children did achieve seizure freedom up to 25% and a seizure reduction up to 60%. In the adult population, seizure freedom was not identified, but up to 35% seizure reduction was seen in the modified Atkins that was applied for adults. As well, in this Cochrane review, which was interesting to see, there was a description of gradual onset ketogenic diet versus fast onset of ketogenic diet, and what was identified there was seizure freedom did not differ. Seizure reduction in the gradual onset ketogenic diet, however, seemed to be higher. Common adverse effects of ketogenic diet therapy were gastrointestinal syndromes, and adverse effects were a common reason for dropout. Other reasons for dropout were lack of efficacy and non-acceptance of the diet. So the conclusion was that the ketogenic diet therapy is promising for epilepsy management. The classic ketogenic diet is associated with more adverse effects, and attrition, dropout, is associated with lack of observed efficacy and diet tolerance. The limitation to the study, of course, is that the study period was short. But what about adults? A meta-analysis put forward by Yi and their group in 2015 took a look at 270 patients and found that in all diets, when combined together, there was about a 42% response rate in seizure reduction. The classic ketogenic diet reported to have a higher seizure reduction rate, and the modified Atkins at about 34%. Challenges of compliance was about 45%. The classic ketogenic diet had a 38% compliance rate, whereas the modified Atkins had a higher, because maybe perhaps of less restrictiveness, at a 56% compliance rate. But the main reason for discontinuation in the adult population was lack of efficacy. And as many of you know, there has been a consensus statement by the International Ketogenic Diet Study Group that has described in 2018 in Epilepsia about the optimal clinical management of children receiving ketogenic diet therapy for epilepsy. And the ongoing recommendations continue to be that, for the purpose of this presentation, is that we should be teaching and counseling before our initiation. We should provide nutrition evaluation of the current diet, look at the eating pattern, look at anthropometric data, review the laboratory tests, which is outlined in the article, as well as possible investigations such as ECG and EEG. And then understanding what your target endpoints of evaluation of efficacy should be. What should the patient and family's understanding of success of seizure control be? An evaluation of social circumstances and supports in the community. Should you begin the ketogenic diet therapy is also one of the things that we look at. Is once we do our assessment, pre-ketogenic diet assessment, is at the end of our assessment, should this be the step that our patients should be taking? So when you look at the variables when considering ketogenic diet initiation, we break it down in sort of four sort of variables: the family, the community resources available, the ketogenic diet team that is available, and the hospital resources. Now, each of those has their own sort of in-depth discussion of analysis, but we'll be looking broadly towards talking about all of those throughout this presentation. And as well, we're going to look at methods of initiation that have different variety of approaches. So this is sort of the rationale behind us, as we looked at the different methods that exist. Is there an outpatient or inpatient initiation methods? Do we do slower rapid titrations? Is hydration restriction or no hydration restriction required? Is fasting or non-fasting leading into initiation needed? And how do we need to titrate the ketogenic diet, and what is the best fit for the family? So the overview of rationale and history of low-ratio, slow outpatient initiation. We'll first look at our outpatient or inpatient initiation. So in 2001, we used to have an inpatient admission methodology where we called it the rapid initiation, and in there we would have about a 5-day admission. We may or may not fast or begin the ketogenic diet on day 1, and then advance the strength on day 2, 3, and 4, and then on day 5 either hold steady and maintain or adjust again, and then hopefully discharge to home if stable. The teaching of the parents, meal preparation and monitoring expectations would occur maybe just before or during that admission. We would require daily blood work from the patient and monitoring for metabolic fluctuations. And then once discharged home, the dietitian would provide phone support and menu support intensely for about 4 to 6 weeks. The challenge of inpatient initiations, of course, is obvious. It is challenging for the patient itself. They require rapid changes to the diet within days, as you see from the outline, and the diet may be more restrictive than perhaps necessary. So the side effects of rapid initiation can also be hypoglycemia, acidosis, nausea, vomiting, and diarrhea. And so we observe that as well with inpatient initiations. But the challenge to the keto family needs to also be considered. So there could be time away from work and home, or there's a learning within a hospital environment using unfamiliar kitchen facilities. There's multiple distractions and limited foods compared to what is available at home. Again, looking at the different variables of initiation, there's challenges to the hospital. So bed availability is a challenging issue for Canada because we are a socialized medicine model where we are publicly funded. So bed availability is usually maximized, and trying to obtain a bed for these initiations starting on a workday Monday is very challenging and difficult. There is a possibility for extended length of stay because we might drift into weekend work, etc., and we can't continue the initiation until the dietitian is back to work. And as well, the cost of the admission to our Ministry of Health. As well, the challenge to the registered dietitian and the team is that it is a less efficient use of our time due to having to split your responsibilities both to the inpatient world and concurrently to your outpatient responsibilities. Many of us do both, but it's nice to be able to have more weight towards one side so that you can concentrate your time. And as a result of inpatient initiations, we were experiencing a lot of overtime hours. So with the outpatient initiation, we hypothesized, could the diet be initiated while the patient remained in the community, the home or residential setting? Was it appropriate for patients who were more medically stable or who could not accommodate an inpatient admission? A particular population that comes to mind are children who have very difficult time changing their surroundings and behaving in different surroundings. So we often feel that if we can, we'll try to initiate in an outpatient basis. Thirdly, medically stable and hospital beds are not readily available. So is an outpatient initiation possible? Use of foods at home and the community environment to initiate the ketogenic diet. Could we do that in such a vast province? And could we use rapid or slow titrations of the ketogenic diet? So those were sort of our thoughts behind starting off the outpatient initiation thinking. And then we thought, well, let's look at all the different types of titration methods for the ketogenic diet. So many of you know that there is the ketogenic ratios. So ketogenic ratios is described in numbers, 3-to-1, 4-to-1, 2-to-1, etc. And what it is really a math description where the first number represents the amount of fat in grams, where the second number represents the sum of grams of protein plus carbohydrate. And in the ratios, the titration method that is traditionally used is to advance by ratios, advancing anywhere from 1-to-1 to 1.5-to-1, 2-to-1, etc., or taking bigger leaps, 1-to-1, 2-to-1, 3-to-1, etc. But again, remembering that it is a math equation. The challenge with ratio methods, advancing using the nomenclature of ketogenic ratios, is that it is difficult to compare the ketogenic diet prescription when describing it. Ratios don't necessarily describe the grams of protein and carbs, which is your denominator of your equation. So using the example of a 4-year-old boy, 15 kilos, requiring 1,200 calories, you can see that in the table below, 3-to-1 ratios described in both prescriptions, same amount of fat, but if you jot your eyes over to the right, the grams of protein are different and the grams of carbohydrate are different. And those that know ketogenic diet therapy very well, they'll see that that a 10-gram restriction per day of carbohydrate is far more restrictive than 24.7 grams. But when we describe our ketogenic diet in ratios, it is not as descriptive to us. So when we are titrating as dietitians, we really have to understand those numbers. Method number 2 is you can titrate the ketogenic diet via percentage of calories and or grams of macronutrients. Again, using the same example, you can see in this particular boy, we used the regular diet and analyzed it, and he had about 33% calories from fat, 53% from carbohydrate, and 14% from protein. And over there, we translated those into grams of macronutrients. And then when you describe your titrations, let's say we titrated the percentage of fat from 60%, 70%, and 80%, as you see from step 1 to 3, you can translate that over to your grams of fat and see that there is sort of even jumps of titrations that seem to be more appreciable. That you can actually understand what kind of change you're making when you actually do it by percentages and grams. So you can see with 60, 70, and 80% adjustments in the percent calories from fat, when you will go over to the grams of fat, you can see the jumps from 80 grams to 93 to 107. It's jumps of about 13 grams. And again, it gives you an example of it being a little bit more descriptive and precise and understanding what kind of prescription you're giving to your patient. Just moving. Method 3 is about trying to set an initial goal of grams of carbohydrate per day. So we see in the modified Atkins diet, you can set the grams of carbohydrate right down to 10 to 20 grams a day, and then you can encourage high fat intake and encourage the protein. Whereas in the low glycemic index diet, you have a less of a carb restriction of 40 to 60 grams of carbohydrate per day and encourage your fat intake. So it's sort of like that, just like one-time prescription, and then you can modify a little bit. Now, meal plans can certainly be prescribed by the dietitian, but if no meal plans are prescribed, there's a possible disadvantage of less precision. And from a dietitian perspective, there might be more diet analysis that's required, diet history taking and diet analysis that's required when you do your follow-ups with your patients on this method. And finally, with method 4, how do we sort of modify and titrate the practical tools of titrating the ketogenic diet? Now, what exists right now is the custom menus that we can create through Keto Diet Calculator and EKM that's used in the United Kingdom. We can use fruit and vegetable exchange lists that existed when I started my practice in 2001, or we can use these fat, protein, carbohydrate exchange lists that we see for the modified ketogenic diet in the United Kingdom, the MAD diet, low glycemic index, or we can even, the low glycemic index diets, or even what we have now for our own self with the low and slow. So the next part of our rationale and history was to evaluate slow versus rapid. So just to take you down a bit of the history, in our practice at McMaster, we have attempted all sort of possible scenarios, scenario 1 to 4, where on scenario 1 we advanced by strength. Each day we adjusted the strength and titrated up over a period of 4 to 5 days. In scenario 2 we titrated up via ratios, and then again over a period of 4 or 5 days. In scenario 3 we titrated up by percentages, and then in scenario 4 we just hit a carbohydrate target and then encouraged our high fat intake and protein for the day. The challenge, however, for rapid initiation is that the question always came about is, are we restricting too much? Are we achieving the least restrictive, effective ketogenic diet prescription? Because we don't have enough time between the days of titration, we don't have enough time of observation to see if the current step is prescriptive, our rationale was that we might be overly restricting. And as well, what we found, and you might find in your own practice with rapid initiation, there is more metabolic fluctuations of hypoglycemia and acidosis that required intervention. Now, again, with our rapid initiations, the one thing that also came to mind was communicating through our medical team needed to be effective and clear. So again, going back to the 4-year-old boy, 15 kilos and 1,200 calories, we needed to figure out a way to communicate where our titrations were going to happen slowly or rapidly. This is sort of an offshoot, but I wanted to discuss it, is that with the different methods of communicating, we eventually decided and concluded that communicating by ratios is a bit inaccurate, can lead to medical misunderstanding, because we might, as dietitians, be adjusting the protein for our patients, etc. So we would eventually decide that we wanted to communicate by percentage of calories and fat and grams of macronutrients to have a more accurate description of our ketogenic prescription. Whoops. So going back to the advantages of what we hypothesized for this low titration was that we would attempt a gradual reduction in carbohydrates and a gradual increase in fat over a period of weeks, rather than the rapid titration, which was happening over a matter of days. The advantage that we hoped to gain was that we'd minimize the side effects of hypoglycemia, nausea, vomiting, acidosis, and hyperketosis, that it did not need a hospital admission to manage side effects. Our families could adjust to the new lifestyle gradually and in their own home and environment. There were longer windows of observation to monitor the efficacy of that current ketogenic diet prescription, and therefore avoid unnecessary high restrictions. My ketogenic diet time is not as concentrated and permits more balance of my other duties at work, and my patients and families can gradually ease into the new ketogenic diet lifestyle. The disadvantage that we were hypothesizing was that it may take longer to see seizure control with the slower titration of ketogenic diet, but this remains to be determined because we're achieving ketosis in a more gradual manner. So in 2004, I reviewed what was going on in the literature at the time, and not much was yet evolving. There were a couple of studies that were put out by the Wirral group and the Valsleb group about outpatient initiations, probably all of us thinking in the same mindset. One of them is a Canadian group as well. So I think we were faced with the same challenges of bed availability. Could we be doing this as an outpatient method? I know Dr. Eric Kossoff was starting to evolve his modified Atkins methodology, as well as the low glycemic index coming out of Boston, Massachusetts General. So, I think a lot of people were thinking along that time, could outpatient initiation be possible? And so if I draw your eyes over to the right, the low ratio slow initiation method started to take on the following framework. This would be done as an outpatient. We'd have a 3-hour clinic appointment to provide keto diet education prior to starting. We would slowly titrate the ketogenic diet prescription every 7 to 14 days, which I'll provide more detail in the next coming slides. There would be the fundamental for this method is you have longer windows of observation to see if the diet is effective. And the titration method we chose to use was to use percentage calories from fat, protein, and carbohydrates, and as well to describe our prescriptions in grams of macronutrients. And as a result, the ratio does not become our goal, but it becomes a result. And our ultimate goal for the low ratio slow initiation method was to achieve the lowest ratio, least restrictive diet possible. We could adapt the principles of the classic MCT, modified Atkins, low glycemic index diet, classic diet as well, and it could all be encompassed as we titrated in. And what I've learned over time is that as we titrate in from one common place, we can learn through the journey as we titrate in those steps what is the best sort of diet that fits that particular family, rather than having to decide right from the beginning. It just buys us a bit more time to figure out what will lead them to better success and higher compliance. So we also hypothesized that there would be less occurrence and less severe metabolic fluctuations with a slower titration, and that I would have to work less overtime, and our dietitians work less overtime now because of the slow outpatient initiation, and could more than one initiation occur per month because we could stagger our initiations. So the evolution of low and slow started in 2005, where we started our first ketogenic diet patient at McMaster Children's Hospital, and from 2006 to present day time, over 90% of our initiations are via low and slow. And so as we started to have acquired more and more patients on this method, we felt it prudent to look at our safety and tolerability data. And so our group of neurologists and myself gathered a snapshot of the data. And we were very thankful to have the support of our Chief Scientific Officer, Dr. Heather Arthur, to support us on this endeavor. And the aim of that study was to evaluate the safety and tolerability of the low and slow method, and secondarily on its effectiveness of seizure control, and then finally sustainability. So we took a snapshot of our patients, and we took the first 30 consecutive pediatric patients that started on low and slow and evaluated them at the pre-initiation first month, third, sixth, and 12th month, and collected data on the following endpoints that you see below. We triple extracted the data, and we made definitions of hypoglycemia that we use in practice as 2.9 or less. We identified our acidosis endpoints, and as well we defined normal acidosis to be 22.1 millimoles or above, and then we also obtained our beautiful SPSS programs and analyzed our data using a one-way ANOVA. And as to go through this, as if I draw your eyes quickly to the top left box, you can see that by using the left margin, the percent calories from fat, percent calories from carb, and mean ratio on your left-hand side, you can see by month 3, if you want to talk ratios, we achieved a ratio of 2.3, and it remained fairly steady at that ratio from 2.3 to 2.4 until the 1-year mark. The percent calories from fat prescription was about 81.5% calories from fat, and again remained fairly steady until about the 1-year mark. And then the percent carbohydrates, which is the palatability piece of our diet, we were able to hold it at around between 8 and 9% calories from carbohydrates. In terms of tolerance and safety, we did not experience hypoglycemia. If you look to the table to your right of blood glucose, ketones, and urine ketones, we achieved a steady state of blood sugars ranging in the mid-4s. Blood ketones ranged in the initial month 2.9 all the way up to 3.6 and held at a steady state, and then our urine ketones ranged in the mid range of our usual urine sticks between 8 and 9. And then in terms of any symptoms of nausea or vomiting, only one occurrence occurred at the 3-month mark, and then another one occurred at the 6-month mark. Now, of course, people want to know if it was effective in terms of seizure control. So what we observed at the 1-month mark was that it was effective. We could start to see seizure reduction at the 1st month, and then we were able to see it again, continue to go on at the 3rd month, and so on and so forth. So our response to this low and slow method seemed to be in keeping with what has been published in larger size studies. So what you see here with the acidosis measurements, which I think many of you do measure, is that we'll measure whatever was available at the time, either total CO2 or bicarb levels, and you'll see most of the time our patients remained above 18. So we start to get cautious when it goes below 22. We accept as low as 18, and below that we might start to ask about symptomology, etc. But you can see at the pre-keto all the way up to 1, 3, and 6 months, most of our patients remained in an acceptable acidosis measurement. And again, any burden to our healthcare system is always looked at. So we wanted to make sure that if we did this by low and slow method, that we weren't creating a rebound into our emergency department or hospitals. So we monitored that as well, and we looked at the 1 month, 3 month, and 6 month mark. And typically our initiation phase is done between the 1st and 2nd month, but we still wanted to see long-term stuff. And so we found that nobody admitted in that snapshot of data that we did. Nobody admitted because of side effects related to our initiation. And as well, we reviewed our ECGs and this was measured at 6 months, and there was no concerns requiring change from usual monitoring. So what is the low and slow method? So the low and slow method is step 1. We take our patients, we screen them for inborn errors of metabolism that is contraindicated for the ketogenic diet, as the consensus statement requires us to do so. We do an outpatient teaching assessment with the dietitian and our ketogenic diet team. We get a pre-ketogenic diet history of 5 days. We collect from either the patient or the family or both, and we will do our routine baseline ketogenic blood work and baseline ECG. And from there, the dietitian will do a pre-ketogenic diet analysis and determine the average intake of grams of macronutrients and the percent calories from fat, protein, and carbohydrate. The general overview of the low and slow method before we begin into the steps is there's generally 4 titration steps. You might take sub-steps in between, but there's generally 4 steps. You want to work with predetermined goals at the beginning of your titration. You want to find the most effective ketogenic diet prescription that is the least restrictive to support seizure control. For children, you want to be able to provide enough calories to support acceptable growth. Now, the percent calories from fat is advanced with an effort to also calculate carb and protein to meet the needs of the patient and achieve palatability. The ratio is the result, but not the goal. Not all titration steps are required. As I said, there could be 4 steps, but if you're achieving acceptable seizure control, then you can yield at that particular step. The typical duration of the low and slow method is about 4 to 8 weeks, depending on how many steps is required. And after the initiation phase, the patient and family enter the maintenance phase of ketogenic diet therapy. So going into the steps. Titration step 1. Determine the energy requirements to support your ketogenic patient. Increase the percent calories from fat by 20% or start at 60% calories from fat, whichever is appropriate. So that's sort of the judgment of your team, your dietitian, to say, is a 20% increase more, easier for your particular patient to transition to, or can they just straight jump to 60%? So that is a judgment call on your team. Then you try to meet the protein needs of using the minimum of DRI, or you can try to echo your pre-ketogenic diet intake, whatever judgment you take there. But then your carbohydrates make up the additional calories. And again, the ratio is not the result. It is the goal. The ratio is the result, but not the goal. You maintain this step for about 7 to 14 days. Allow them to adjust to the shopping requirements, the meal time, the meal preparation requirements, trying to operationalize the diet at this titration step. And in that, they're also trying to encompass sort of the monitoring that we expect of them. So we want them to do daily blood sugar testing, urine testing, weekly blood ketone testing, multi-stick urine tests, monitoring bowel movements, as well as seizure control, and we provide them with a monitoring sheet to do so. And then when deemed necessary, we might ask them to go to a local lab to monitor for acidosis. Titration step 2. So if you're advanced yourself to about 60% calories from fat, then you can advance again by another 10 or 15%. Again, your protein needs should meet the minimum of DRI, and then you round out the rest of your calories from carbohydrate. And then you may or may not consider adding MCT. Again, you have to figure out what's best fit for your family, and the ratio is a result, not a goal. The duration of this step is again 7 to 14 days, or you can maintain at this step if seizure control is great at this step, then you can maintain at this step. You have a nice broad window to monitor. And again, the home monitoring does not change. Blood sugars, urine ketones, blood ketones, multi-stick and seizure control is expected, as well as bowel movements. And then if we decide is necessary, to move on and get some acidosis blood work done in the community. If seizure control is still not acceptable, you move on to titration step 3, where you advance the diet by 5 to 10%. And then again, meet your protein needs and round out the remaining calculations using your carbohydrate. You can add MCT oil or not. It's up to how you assess that family to be. And the ratio, again, is a result, not a goal. You maintain that window of observation to be 7 to 14 days. And if it is you're getting acceptable seizure control, then remain at that step. And if seizure control is still not acceptable, move on again to step 4, where you advance by the same percentage again, by 5 or 10%. Monitoring throughout the steps remains the same. So we ask the families to try to be vigilant about watching for hypoglycemia, ketones, and acidosis symptoms. And we also teach them how to do correction just for the sake of safety. So as a role for our ketogenic diet team and dietitians, we decide the calories for appropriate growth if this is for children, decide the protein and carbohydrate to support the palatability and efficacy. The dietitian can create menus to best fit the ketogenic diet prescription to optimize the palatability. The registered dietitian can provide weekly or biweekly monitoring and support via phone or email with the caregivers. And the multidisciplinary clinic visits will start to occur at 3 months. 6 months, and every 6 months thereafter. Some questions have come to me whether we actually will do clinic visit at the 1 month mark, and we do not, because we're still in the titration mode. So we've been able to release that clinic visit, and we're able to, allow from a socialized medicine point of view, that's an advantage because we won't be taking up that clinic space, and we'll be replacing that with probably a phone follow-up. And as a dietitian, we often use tools that are out there in the community. It's very prudent that we use tools that are very evidence-based and peer-reviewed. And so Matthew's Friends and Matthew's Friends Canada are great resources of evidence-based information and practical tools. The Matthew's Friends, based in the United Kingdom, has provided a very amazing website, YouTube channel that provides, recipes and YouTube channels and a lot of practical tools and guidance on how to operationalize the diet. And so as a dietitian, we use those tools to help guide us for our families, to help provide sort of practical tools, and as well to demystify how difficult the diet can be. In Canada, we've been working with the Dietitians of Canada, and through the Dietitians of Canada, we have 9 practice and evidence-based nutrition tools that have been reviewed by our medical advisory board that include very experienced ketogenic dietitians and physicians across Canada that have contributed to the content of these tools, and as well, the Matthew's Friends Medical Advisory Board has provided sort of the fundamental topics for us, and as well they've contributed to those tools. So another piece that I would like to add is the observation that we've had in practice with the low and slow method. And I think it's not particularly specific to low and slow, it's just the challenge of ketogenic diet method, but we decided to analyze it in the context of low and slow. So when it comes to oral feeding and the ketogenic diet, we encounter many challenges. There's the limited choice and variety of foods that can occur. Menu creations can be limiting depending on the method that we use. As I mentioned earlier, it can be time consuming for a dietitian or a caregiver to calculate menus using a ketogenic diet calculator, especially when variety of foods is desired. There is a need for adaptability of diet food choices to be available in both grams and household measures. There's a need for adaptability, being able to include foods local in their area. And there's a risk of discontinuation or dropout with oral feeders due to reasons above. And we saw that even in the Cochrane study that we mentioned earlier. So what we've developed here at McMaster Children's Hospital is a exchange system method. And this is a very overwhelming slide, but just to let you know like how we have these carbohydrate exchange lists, fat exchange lists, and protein exchange lists that we use in our low and slow method. This is our carbohydrate exchange list. This is our protein exchange list. And this is our fat exchange list. And then as dietitians, you know that some foods don't fall in one category exclusively, so we do have a combination food exchange list. And we do have conversions. So what did we decide to be a protein, and it had to fit the criteria you see on your screen for carbohydrate, fat, etc., and combination food. So we had a wealth of support to try to create our databases, to create lists of protein, carbohydrate, and fat so that we could share those education tools with our families so that exchange lists could be populated, it could grow, it could adapt to the environments that our multicultural society allows, and so. But we just needed to define the criteria. So exchange lists can actually take on different cultures, different food availabilities, depending on where you reside in Canada or the world. So here is an example of a ketogenic dietitian's prescription of ketogenic diet that we use here for our oral feeders. So based on the titration methods that I described just earlier, step 1, 2, 3, and 4, you can see now, instead of describing it in terms of percentage calories of fat or grams, we now translate those into exchanges. And this is what the families will see. This is not, we also see this, but this is what the families see. It's less overwhelming, and we just say, okay, for this particular patient, step 1 will begin with this many exchanges of fat, protein, and carb. And if there's not acceptable seizure control, then we titrate up to step 2, and they can use that particular prescription. We use the exchange lists often. And actually, I think most of our oral feeders will actually start with the exchange system because it allows for independence, less dietitian dependency, but it does require education, which we educate right up front at that initial experience with us. So our assessment phase, which is about a 3-hour teaching session at the beginning. If the family is too overwhelmed to consider the exchange system method, then we will consider just calculating out the menus for them until they're ready. But eventually we'll try to guide them to have more independence to creating their own menus. So again, to be responsible to the new method that we created, we wanted to take a safety and tolerability and also a retention data on the particular food exchange method. And so we took a snapshot of, again, our patients, and we studied the first 20 that we implemented on the low and slow method using the food exchange method. And our inclusion criteria was those patients that were taking more than 50% of their calories orally and using the food exchange meal plan throughout the study period. And we measured the tolerance variables and safety variables as acidosis, hypoglycemia, ketosis, seizure frequency, and as well, what was interesting, we wanted to know is our patient retention rate and reasons for discontinuation. And what I wanted to quickly draw attention to was that we were very pleased to see that with the 20 patients that we were analyzing at the 3, 6, and 1 year mark, we were able to see very little attrition. So our sustainability, it's suggesting that we have a good sustainability plan with our oral feeders using the food exchange method. The one patient that did withdraw from treatment was due not because of food availability or food acceptance, but more so because the diet was not effective for seizure control. And to give you a context of an example of how this is applied, this is sort of the whole lecture combined into one slide. You can see to the very left in the purple table, week 1, 2, and 3, week 4 and 5, and week 6, and different titration steps. So steps titration 1, 2, and 3. And you can see the prescriptions in terms of percentage calories from fat, protein, and carbohydrate. And you can see with each titration step, the percentage calories from fat go up and the percentage calories from carbohydrate go down. And as we took each titration step, it translated into different exchanges of fat, protein, and carbohydrate, which is the part that the patient will see. And through this example of the same patient, 4-year-old boy, 15 kilos, requiring 1,200 calories with myoclonic astatic epilepsy, we found that through these titration steps and using the exchange method, there was only one hypoglycemic event, minimal acidosis, no nausea, no vomiting, urine ketones within 4 to 16 millimoles, which is showing us good production, and sugars that remained within acceptable limits. So from our safety and tolerability data as well, we were able to see, bringing it back to the study, we were able to see that by 1 year, we were able to maintain our patients with only one person leaving due to lack of efficacy. But again, we found similar results. By about that 3-month mark, we were able to stabilize the ketogenic ratio at about 2.3 and then hold around 2.4 to 2.46. And our percent calories from fat and carbohydrate remained fairly steady from the 3-month point onwards. So again, I bring, using all our various tools out there, we do have the Keto Cooking channel that Matthew's Friends populates with so many practical videos of how to prepare ketogenic meals. And I think it is a good way to show our families that, even with using exchange methods, that you can pick all the ingredients that you want from your exchange list and look to the Keto Cooking channel and create recipes. And the instructional value that you get from the cooking channel really works well and in companion with our food exchange system. And in there, you will see Emma Williams cooking, Mo, and as well as Chef Neil and other guest chefs that are providing practical and simple recipes. So the conclusion is that the low and slow method is safe and well tolerated. You allow for broader times to watch your prescription. We like to have smaller titrations of percent calories from fat and carbohydrate because it is associated with good tolerability. We have sustainable seizure control at 1 year, and we feel that our seizure control is achievable and sustainable, and ratios are a result, not a goal. And our seizure frequency reduction when you do low and slow is reported within the first month of initiation, so you will start to see that seizure reduction. Seizure control appears to be similar to previous studies when compared to rapid ketogenic diet initiation. The results suggest seizure frequency reduction can be achieved with lower than traditional ketogenic ratios, and our food exchange lists companioned with dietitian supervised meal plans is a useful tool to allow more variability and independence in menu creation by the patient and family, and suggests that it positively supports retention of patients to continue the diet therapy. And I know I'm running short of time, so that's just the practical examples that I've kind of reiterated throughout the presentation, which I know you'll get copies of as you conclude this presentation. Acknowledgements go to, of course, my colleagues at McMaster Children's Hospital in the Division of Neurology, my colleagues Nicole Turner and Nadine Nevland, as well as all the students that have supported this project, my mentor, Dr. Ronan, and as well Dr. Heather Arthur. And special acknowledgements to Emma Williams and Julie Fountain over at Matthews Friends for taking me under their wing and supporting us here in Canada. Great. Now I'm ready to take any questions if there are any.
Thank you, Jennifer. We are going to move to the questions portion of the webcast. So for those of you joining us later, please use the function or the panel on the right-hand side where you can type in a question that you would like to ask Jennifer. We do have some questions that have already come in, so I will read the questions to you. We have Helena Champion asking, did you find your dropout rate before 3-month assessment for efficacy was different between the hospital and outpatient groups?
The outpatient versus hospital groups, I haven't done the comparison. To be honest, that's a good question. So to compare inpatient initiations, if I understand it, inpatient rapid versus outpatient low and slow methods, I haven't compared, in a rigorous sort of comparison. But if I were to, I think that that's a hard question to ask in that we also have, I think the other variable that you have is also your team, and how much team you can support on the inpatient side. So you're comparing team support on the inpatient side versus team support on the outpatient side. But yes, I have not done that rigorous comparison. I can tell you from experience that I feel that our inpatient rapids seem to fall off the ketogenic diet more so if the side effects are actually more severe. But no, I haven't done a very more rigorous comparison.
Okay, we have another question from Denise Potter. As you titrate up, are you providing specific menus for each level? So there's a series of questions, so I'll stop right there. So the first one is, as you titrate up, are you providing specific menus for each level?
So if the family is not able to do the food exchange system, then we will calculate out the menus for them, but that is a very time-consuming process. But we're willing to support that. We do have enough manpower to create individual menus for that family. But over time, we want them to be able to take on some independence. So we want to empower the family. So the food exchange system is very important. So all they need to do is look to the prescription of the food exchange system. So and then translate that over to what meal they would like to create that day. And then they have more independence on how what foods they have available, what they like that particular day. It's very successful with selective eaters and food availability at that particular time, because there's many times, you open your fridge and you're out of blueberries or you're out of strawberries. But if you have a food exchange system that you can do a lot of, immediate swap outs, it's very effective. So we do, if we feel that the family cannot take on that food exchange system, but we do eventually graduate them over to the food exchange system.
So this is a follow-up. What percentage of the time are you providing special or specific menus for the families?
What percentage? Oh, it's very little. For oral feeders, we'll probably provide it less than 5% of the time. And of course, for our tube feeders, that's a different. We will provide the prescription 100% of the time.
And the third question is, are they tracking on an online app?
That is in the works. So the online app is definitely on the works. Some people will track their seizure control on a certain app, but that definitely is the next step, is to create sort of the app conversion of sort of all our blood sugars, blood ketones, as well as our exchange system. So that is in motion as we speak.
Another one from Helena. Do you think you maintain lower ratios that give seizure control as you may add MCT fat in step 2 titration?
I do. I think we do feel that we achieve lower ratios because we can figure out whether they could benefit from an MCT so that we could spare the carbs. So that might be a reason why we achieve lower ratios. Not every child or adult is getting MCT, but we do consider it. And like I said, with the low, slow entry into the ketogenic diet, you start from one common place, and then as you dialogue with that family, you negotiate, or you assess, and you figure out whether perhaps they can go, the MCT route, or perhaps they'll be more beneficial the classic route, or maybe they need a little bit more liberalization and they can go the low glycemic or modified Atkins route. So we don't try to negate not doing any of the methods. We just start at a common point and then consider what would be the proper fit for that particular family. And it's dynamic. As many of our seasoned dietitians know, you can start in one place and start with MCT and introduce it so you can spare the carbs and improve palatability. But as you go on, you might move over to a classic, or you might liberalize to a modified Atkins as the journey continues. But all I'm describing in the beginning here is that, we start at a common point and then assess as we go along slowly.
We have lots of questions coming in, so we'll try to get through these here. Using the principle of the MAD, this is, again, I believe, Helena, do you think you could relax the exchange list to allow protein for appetite?
Yes, absolutely. Absolutely. So the exchange list that I provided you is only as an example, right? So again, I never want to take away from the dietitian judgment. So in your exchange system, you can decide the prescription of what you wish for protein, what you wish for MCT, if that so wishes, what you decide for carbohydrates. If you don't want to do 20 grams of carbohydrate for MAD or higher for low glycemic, absolutely, you can relax to it. But it's just nice to go to the exchange list and have that translated for the patient really quickly.
Kelly Groth asks, are you doing ketogenic tube feeding titrations in the outpatient setting as well?
Yes, absolutely. Again, 90% of our initiations are via outpatient low and slow method, and that includes about almost 50% of our population is tube fed, and the remaining are oral feeders. And we do both populations, tube fed and oral, via outpatient method, and have been doing so for years.
Alicia asks if the patients are weighing foods.
The exchange list allows them to weigh foods, and as well allows them to use household measures. We felt that there was a need to include household measures because there are some families that perhaps cannot afford a scale, even if we try to find an economical one for them, or can't obtain the scale because it's just not a resource they have in their community, or that it just was too much for them to learn. So we've just encountered over the years many populations. So we did feel it prudent that we had to use some household measures to at least give them some guidance on accuracy. It's certainly not as accurate. I know the dietitians are going to say it's not as accurate as a scale, but certainly we provided it because it's better than guesstimating.
Eleni asks, is there any indication of long-term ketogenic diet adherence and insulin resistance?
And insulin resistance. So that is a big question that I don't think I'm prepared to answer today. There's a possibility that there is maybe some longer term evidence that there is a development of insulin resistance, but I would have to not be the one qualified to answer that question right now.
Okay. And then Dana would like to know, how would you typically wean a child off of keto? Do you use specific low and slow weaning method?
Yeah, that's a great question because I feel that there's not enough out there described on the weaning of the ketogenic diet. So if the ketogenic diet is effective for supporting epilepsy, we will do a slow titration downwards, and we will do the same nomenclature language of taking it down. So we will go down by percentage calories from fat, protein, and carbohydrates, or grams of macronutrients, whichever is suitable at the time, and we'll titrate it down incrementally, like we will do it in so that it's even titrations downwards. We don't do it by ratios at all, and each step is probably separated, again negotiated with your team, but typically taken down every 2 to 4 weeks, and sometimes slower if needed.
This question is from Wang. I'm not sure how to pronounce the first name. Thank you, Jennifer, for a great talk. Would you mind sharing your exchange list?
Yeah, so the exchange list is now going into our, we're going to put it through our McMaster Innovation and have it printed. So that should soon be available for access. So right now it's in a draft form. So we are going to have that nicely, formatted so that it can be used and shared with those that want to use it.
Alicia asking, do you have examples of menus that you would provide to patients? Are they daily menus or weekly menus?
So yes, I do have examples of, if I were to use the menu method, yes, I would have examples of my own menu methods. But if I'm using the food exchange method, the families are selecting their fat choices, their protein choices, their carb choices. I'm not selecting for them. They're using the exchange list, and however they wish to, what foods they choose to eat is up to them, as long as it keeps within the the grams or household measures that's described within the food exchange system.
This is a question from Nancy. How many times a day are you recommending blood sugars should be checked? Do you provide the ketone meter and blood glucose meter to the family, or do they purchase it out of pocket?
Good question. So we're very conservative here because it was sort of a new method for us to do, but I know we haven't really relaxed on our monitoring, but we do cap blood sugars every at least twice a day. But I know that's very conservative recommendations at the initiation phase. And then once we're past the initiation phase and we have a trend on the sugars and, monitoring for hypoglycemia, which there usually is minimal, we start to relax on that monitoring of the sugars and do it once or twice a week, or if they're symptomatic of hypoglycemia. To answer the second part question, we do provide a meter here. It is by Abbott. And it measures blood sugars and blood ketones in 1 meter.
That was actually the follow-up question here. What typical breakdown, this is Laura, what typical breakdown between enteral feed and oral diet in terms of numbers?
Numbers in terms of my caseload? So in terms of our caseload, we're probably at least 50% of our caseload is exclusively tube-fed. And then we have our oral feeders, which is probably more like 40% oral feeders, and then 10% is a combination of tube and oral.
Okay. We have Kelly asking, are you doing low and slow with infants, or are you admitting them so you can keep a closer eye on them with labs, etc.?
Yeah, good question. So we are, our team has been supportive, and we have been initiating our infants as an outpatient low and slow. And we might take slower titration. So that's why in the low and slow method, there's ranges of how much titration you want, and to judge that. But we have had, haven't had any issues with our infants titrating it. And by infants, we mean from 6 months and over. Usually if we're asked to intervene on a ketogenic diet for somebody younger than that, they might not be stable enough and might be doing that as an inpatient.
We're getting to the end here. I think we have one last question. Oh, I misspoke. We have 2 questions left. So this is again from Dana. Do you incorporate intermittent fasting into your practice? If so, what scenarios would you consider it for?
That is a good question. Intermittent fasting sometimes happens where we need to drive the ketosis a little bit deeper, or to get the ketosis deeper, to get a sort of a jump start. I intermittently do intermittent fasting when I need to, but it's not sort of my common practice. I feel that, if you just continue on with the ketogenic diet, that you'll eventually achieve the ketosis you need. And if you require the intermittent fasting, then perhaps the ketogenic diet prescription needs to be adjusted to drive your ketosis deeper, if that's the point of your goal of intermittent fasting. But yeah, sure, intermittently we can just see if it helps. It gives us a good clue whether the diet needs to be in a deeper ketosis or not. That might be another method.
Yes, and this was the last question. We have just a couple of comments from Emma and Helena thanking you for a great presentation. Definitely echo that. Looking forward to accessing the exchange list. There was a few other inquiries about the exchange list, so definitely interest there. And thank you for sharing these and your practice.
Thank you. Thank you, everybody, and thank you, VitaFlow, for the opportunity to provide this unrestricted education opportunity and for everyone's time and attention. I hope everyone is having a great day today. Just as a quick call out, today is going to be, actually tomorrow is Dietitian Day here in Canada, so thanking all our dietitians across the world for all the hard work that they do in ketogenic diet therapy, and as well in Canada, it's Epilepsy Awareness Month, so as well, thank you everyone for raising the awareness for epilepsy and the treatments thereof.
Excellent. That was wonderful, Jennifer. Thank you. Would you like Bridget to see us off, wrap everything up for today?
Yeah. Once again, very big thank you, Jennifer. That was a wonderful presentation. On behalf of VitaFlow USA, thanks for joining us from around the world. We hope you found the webinar informative and that it will prove helpful in advancing your knowledge and practice of initiation of the ketogenic diet. So the webinar is now concluded, and goodbye from all of us, and enjoy the rest of your day. Thank you.